All right, so we are now at the top of the hour. We'll go ahead and start the webinar. Again, welcome to this IAS-USA webinar. Today is Tuesday, July 26, 2022. My name is Jose Francisco, and I am a project manager here at IAS-USA. We are excited to cover today's presentation regarding the key antiretroviral drug-drug interactions with Mycobacterium tuberculosis infection in persons with HIV, a case-based presentation. We are delighted to welcome Dr. Henry Masur, Clinical Professor of Medicine at the George Washington University in Washington, D.C., who will be moderating our question and answer session at the end of this webinar, and who will also be going our introduction slides. Welcome, Dr. Masur.
Thanks very much, Jose, and thank you, Don and IAS-USA for focusing on a topic which I think many of us need more information on and struggle with. And I think we're very fortunate to have Betty Dong with us, who's a professor of clinical pharmacy and family and community medicine. And she's really one of the national experts on drug-drug interactions. And we're going to focus on TB and not so much Mycobacterium avium, so that we can keep this presentation focused. A few housekeeping announcements. IAS-USA is very focused on making sure that presentations are free of any bias. The board for this content on the web series are listed here. Their conflicts are listed. If you have any issues about that, you can consult this. Specifically today, neither Dr. Dong nor I have any relevant financial conflicts. There are also two reviewers and planners for this. Neither have any relevant financial relationships either that need to be disclosed. In terms of CME information, IAS-USA is an accredited ACCME provider. And on the next slide, you can see that for nurses, pharmacists, and physicians, there are CME credits that you can claim. And if you need any help with that, you can contact IAS-USA. IAS-USA programs are supported by commercial grants, but each program has multiple grants, so that they're not single company supports. IAS-USA makes certain that the content is exclusively the decision of IAS-USA, and they also make sure that any of the sponsors who attend the program attend simply as registrants who view it. They don't take part in any way. If you want to see a review of this within 24 hours, this will be posted on the web at the site that you see here. There is an opportunity to ask questions, but just be aware of the fact that the Q&A button is the way to submit your questions. Chat are a good way to communicate with other people in the audience, but all the questions must be submitted by the Q&A button at the bottom of your screen. We will try to get to them all, and we will do our best, but can't guarantee that we'll get to all of them, depending on how many questions there are. So with that, I'll hand it over to Dr. Dong. She has extensive experience over many years, both dealing with patients face-to-face and dealing with patients by telemedicine. So she's really the person that all the experts consult on drug interactions. So we're very pleased to have her. Betty?
Hey, hello. Good morning, everybody. Can you hear me?
Yes, sounds great, Dr. Dong.
Great. Thank you, Henry, Dr. Masur, for that nice introduction. And thank you, IAS-USA, for inviting me to give this presentation. So you can see my slides here. I have no disclosures. And we are going to focus really on antiretroviral drug-drug interactions with Mycobacterium tuberculosis infection. We had initially intended to also cover Mycobacterium avian, but due to the limited time, we're just going to focus on this presentation. But if you're interested, we can save that Mycobacterium avian presentation for a future presentation. So I have no disclosures, and we have our first polling question. If you could just identify your clinical or academic training or background at this time. Thank you. Thank you. And I think you can see that 36% of our attendees are doctors, 7% nurses, 42% pharmacists, and 7% nurse practitioners and 11% nurses. Thank you. So our learning objectives here, at the end of this webinar, participants will be able to summarize the current treatment recommendations for the prophylaxis and treatment of tuberculosis infection in people with HIV infection, identify the key antiretroviral drug-drug interactions associated with the co-administration of current TB prophylaxis and treatment, and select the most appropriate antiretrovirals to avoid drug interactions when managing persons with HIV and TB infection. So what I'm going to cover in the next hour is to review some of the drug interaction terminology, which we need to understand sort of the pharmacokinetics. But I'm also going to share with you some of the favorite drug resource recommendations to help you identify drug-drug interactions. And of course, we're going to summarize some of the latent TB recommendations and antiretroviral drug interactions and make some recommendations. So this is our first pretest question. Drug interactions between rifampin and integrase strand transfer inhibitors occur because rifampin is a UGT1A substrate, CYP or CYP3A4 inhibitor, UGT1A inducer, PGP inhibitor, or you're not sure. Thank you for your responses. Great, thank you. And you can see the responses here that we will actually go over the right answer during our presentation. So our next pretest question is here. An increased risk of rifabutin toxicity can occur when co-administered with which of the following antiretrovirals? Bictegravir, darunavir, boosted with ritonavir, dolutegravir, doravirine, or you're not sure. Thank you for your responses. And you see the answers there, which we will cover during the presentation. So drug-drug interactions are a leading cause of morbidity and mortality and increased healthcare costs. The potential for drug interactions during latent and active TB treatment is extremely high. From the Drug Watch system, you can see that the number or the risk of drug interaction increases with the number of medications. So there is a 40% risk when 5 or more medications are combined, and that goes up to 80% with 7 or more medications. So definitely when you treat a tuberculosis, latent or active TB infection with antiretrovirals, the potential for drug interactions is very, very high. But in general, I think it's very, very difficult to remember drug interactions and the outcome of each drug interaction. So I want to share with you up front some of my favorite websites for helping you to assess the risks and outcome of drug interactions. My favorite website here is the Liverpool Drug-Drug Interaction Checker, and there is an app for this. And this website is regularly updated by pharmacologists, and they give you all the data and recommendations. Here, you can go to the website, and I've given you the link. I've identified doravirine, lamivudine, tenofovir has the antiretroviral, and I've identified rifampin and rifapentin has the interacting drugs. And you can see on the right side that it says for both of these medications, do not co-administer. If you click on the link of do not co-administer, it gives you all the data, up-to-date data and recommendations. So this is a tip to use this website. It's a really wonderful website if you haven't explored it yet. And I will say that the Liverpool also does a website for hepatitis C drug-drug interactions. And most recently, they have identified a COVID-19 drug-drug interaction website. So I hope you will explore these because they are wonderful websites. Now, for other drugs which don't include or do include antiretrovirals, Mycobacterium is a really nice interaction website. You can actually enter the medications that you want, and then you would check in all the medications on the right side and then check the evaluation for these things. This is an update of all the other drug interaction websites that you can use. I tend to favor the Liverpool and Mycobacterium because they're pretty up to date. The antiretroviral guidelines are great tables, but they don't update them as often as you might need. And there's also lexicon drug interaction analysis. So hopefully you will try using these interaction websites for your next patient cases. And then of course, if you want to talk to a real consultant, this is one of the services that I work for, which is the National Clinicians Consultation Center. It's a free telephone service that is funded by the Department of Health and Human Services and the CDC. And we provide secondary consults for a number of different areas that you can see here on the slide. We do telephone and web consults. So feel free to use these services. And on the National Clinicians Consultation Center, we have 3 pharmacists, including myself, all of which are clinically trained and have active clinical practice. So I think it is difficult to understand drug-drug interactions with TB and antiretrovirals without understanding some of the basic core principles. So I'm going to briefly go through this and then we'll go into cases. So just remember, a substrate is the drug that undergoes metabolism by various enzymes, including the cytochrome P450 system, which I abbreviate as CYP. These enzymes are responsible for more than 90% of drug metabolism that you can see from the circle on the right here. But the most important one is the 3A4 system, which we're going to really focus on that, which is responsible for most of our antiretroviral TB drug interactions. The other system is the uridine glucotransferase, or the UGT1A enzyme system, that is responsible for glucuronidation and metabolism. You can see that 3A4 substrates include protease inhibitors, ritonavir, cobicistat, all the non-nucleosides, and UGT1A substrates include all the integrase inhibitors. So enzyme inhibitors are really important in terms of major mechanisms for causing pharmacologic interactions. And enzyme inhibitors can inhibit both the CYP and or the UGT1A enzymes. And they do that by decreasing drug elimination and causing increases in area under the curve or drug concentrations. Now, because the enzymes are already present, when you give an enzyme inhibitor, you have a very rapid onset and offset, usually occurring the interaction within 1 or 2 doses. Now, sometimes the offset is a little bit more delayed depending on the elimination of the inhibitor and their half-life. So I've listed some common examples of 3A4 inhibitors, such as ritonavir, cobicistat-boosted protease inhibitors, efavirenz, macrolides such as clarithromycin, and you see UGT1 inhibitors such as atazanavir. Now, some of these interactions can be beneficial, and a common one is using protease inhibitors that are boosted with ritonavir or cobicistat to increase their levels. But a lot of times we worry about drug toxicity, increasing levels of drugs causing more toxicities. And common examples of this are statins, where we can see more myositis. Now, some antiretrovirals have both induction and inhibitory activities, such as efavirenz and protease inhibitors, which make their interactions a little bit more complicated, and we will go over these. Now, enzyme inducers do the opposite, of course. They increase cytochrome P450 or UGT1 enzyme in synthesis, so that these kinds of interactions take a little bit more time before they happen. And a lot of times it may be delayed 1 or 2 weeks based on the half-life of the inducer and the need to synthesize new enzymes. And likewise, the offset can also be delayed. Very good examples of these are listed below, like the rifamycins, the ritonavir boosted PIs, efavirenz, etravirine, anticonvulsants, St. John's wort, dexamethasone, etc. So it's really, really important to remember that with enzyme inducers, that because you're making enzymes, that even though you stop the inducer, and rifamycins are really common examples of this, that the effects of the induction can still persist for 2 weeks after stopping. So I want to also talk a little bit about drug transporters, and there are a lot of drug transporters, but I'm really going to focus on P-glycoprotein, or PGP, which really affects drug absorption. This is an efflux pump that is available in the intestine, the liver, the brain, etc. And the primary purpose of the PGP pump is to push the drug out of the cell to reduce intracellular drug concentrations. And so we're limiting systemic substrate exposure. You will find that many PGP substrates are also 3A4 substrates, and that's because the co-receptors kind of overlap. And we'll also see that many PGP inducers are also 3A4 inducers, and their overall effect is to reduce drug absorption. Conversely, PGP inhibitors can also be 3A4 inhibitors, and the effect here is to increase absorption. A common antiretroviral PGP substrates are tenofovir alafenamide, as well as tenofovir disoproxil. And some of the clinical consequences that we see here that I think we all know as HIV clinicians is that TAF levels go up with PGP inhibitors such as cobicistat or ritonavir. So our dosage of TAF is often reduced from 25 to 10 milligrams daily. And there is always concern that for tenofovir, that when we're using a boosted PI, that there might be an increased chance of renal toxicity with tenofovir. We're also going to see some data about reducing TAF levels by PGP3A inducers, and we'll show you that as we go through the presentation. So let's look at the rifamycin and their potential for drug interactions. Now, rifampin is one of our most potent drugs that does induction. It is a triple threat because it induces not only the 3A4 enzyme system, but it also induces UGT as well as PGP systems to reduce both drug level concentrations and reduce GI absorption. And that is one of our polling questions as why rifampin can cause significant drug interactions, because it is affecting induction of all three systems. And therefore, we can see reductions of all the antiretrovirals metabolized by these pathways, as well as other drugs, contraceptives, glucocorticoids, statins, etc. Now, when we talk about PGP absorption, we find that PGP GI absorption is not as significant an interaction as the ones on 3A4 and UGT, but it does add to the effects of rifampin to lower drug concentrations of several entities as identified here. Now, what about rifamycin? Now, rifamycin, in terms of TB treatment, can either be given weekly or daily. And based on some of the PK data, pharmacokinetic data that we've looked at in terms of rifamycin, rifamycin's induction potency is about close to that of rifampin with daily dosing. And some laboratory indicates 85% of the potency of rifampin, and some others are really equal to rifampin. But when we do weekly dosing of rifamycin, we see less drug interactions, but we're going to see interactions with all three systems. Now, what about rifabutin? The induction of rifabutin on all three systems is much, much less potent compared to rifampin. It's about a little bit less than half the potency of rifampin and rifamycin. But the other property of rifabutin that makes it more common interaction is that it is also a 3A4 substrate, so that there can be bidirectional drug interactions potential where the rifabutin concentration can be affected by 3A4 inhibitors and inducers, as well as rifabutin causing induction. So this can be somewhat of a more complicated drug interaction profile depending on which agents that we're combining it with. So what about our other TB drugs? Isoniazid tends not to have significant interaction with most of our antiretrovirals. It does inhibit other CYP3A4 and 2A6 and 2C19. Sorry, it doesn't inhibit 3A4, but it does inhibit 2A6 and 2C19. But that does not interact with most of our antiretrovirals, but can have interactions with other medications. And fortunately, ethambutol and pyrazinamide does not have any significant drug interactions with any of our antiretrovirals. So how do these TB drugs interact with our antiretroviral agents? So I put together some charts here, and what you can see is that bictegravir, dolutegravir, CAB, and raltegravir are all UGT1A1 substrates. So anything that induces these substrates will lower the levels of the integrase strand inhibitor concentrations and lead to potential virologic failure and potential drug resistance. But what I want you to notice between bictegravir and dolutegravir is that bictegravir also is a substrate for 3A4 and PGP versus dolutegravir and CAB, which are really substrates for primarily PGP, whereas dolutegravir has a minor effect on 3A4. So when you look at this, you can sort of predict that drug inducers will have a greater effect on reducing bictegravir levels than on dolutegravir or cabotegravir because of the different substrates. And I'll show you some data about that. And based on these kinds of substrates, we do see that kind of interaction happening with these drugs. So what about the non-nucleosides? And all of these are CYP3A4 substrates. And so they're going to be reduced by inducers of these substrates. And you will also see that efavirenz and etravirine also have inhibitor and induction properties. Again, it depends on what drug they're co-administered with and the drug interactions. Okay, and I'm just going to show you boosted protease inhibitors, not to scare you, but you can see that they are substrates of the CYP3A4, PGP, but besides that, they also have inhibitor and induction properties, which makes their drug interactions much, much, much more complex. So the bottom line is if you see a boosted protease inhibitors, you should be wary that they're going to be drug interactions, and the drug interaction complex can be very complex. Okay, so let's go to our first case. This is JP is a 55-year-old female with HIV infection who's well controlled on M-tricytidine, tenofovir, alafenamide, and bictegravir, who comes to clinic after her sexual partner was recently diagnosed with active tuberculosis. She is asymptomatic. She has a good CD4 of 679, and she's virologically suppressed, chest X-ray within normal limits, and no infiltrates. Her past medical history includes hypertension and history of opiate use. She's currently taking lisinopril, amlodipine, and methadone. So the question for you to consider is which latent TB regimen can be co-administered with her current antiretrovirals? Is it weekly rifamycin, isoniazid, pyridoxine? Excuse me. Otherwise, 3-HP for 12 weeks, daily isoniazid, rifampin, pyridoxine, or 3-HR for 12 weeks, isoniazid plus pyridoxine daily times 6 or 9 months, and 9 months is actually recommended for persons with HIV infection, or rifampin, 600 milligrams daily, 4R times 4 months, or you're not sure. Okay, great. And we'll go over this. So this is a summary of the preferred treatment regimens for latent TB. And right now, the standard of care has really been isoniazid once daily. And like I said, it's 9 months is preferable for people with age, with HIV. And the difficulty with isoniazid is really low, low completion rates and good mortality benefits, and benefits of no drug interactions. But because of the low completion rates, shorter TB regimens, including 3-HR and 3-HP, have now been identified as excellent regimens. So we have 3-HR, which is once daily of isoniazid plus 600 of rifampin plus vitamin B6 to decrease peripheral neuropathy. And it is for 12 weeks. And in studies, they found that this regimen 3R was equivalent to 6 to 9 months of INH. There is limited data in people with HIV. I think the data only shows that about 200 to 300 HIV infected persons were in these studies. And we do have to worry about rifampin drug interactions. 3-HP are once weekly dosing of rifampin plus isoniazid, and you see the doses there, plus vitamin B6. In the PREVENT trial, it was non-inferior to 9 months of INH, and there was higher completion rates and better outcome, especially in people with HIV with high CD4 counts greater than 350. I think we do have to worry about rifampin drug interactions, and we don't have very much data in terms of clinical studies using other antiretroviral agents. And then other ratings include with a B rating, it's rifampin 600 milligrams for 4 months. We have very limited data in HIV. We do see that it was very well tolerated with good adherence and completion rates. But again, we have to worry about drug interactions. And then the 1 HP regimen using 300 milligrams of daily INH plus daily weight-based rifampin plus, of course, vitamin B/C is not right now CDC recommended, but there has been some data showing that the 9-month INH trial was non-inferior to 9 months of INH. And in the brief trial, it was only patients with HIV on efavirenz and nevirapine with a high CD4 count, but we do have some preliminary data from ACT trial that suggests that BID dolutegravir might be okay. So our patient is taking bictegravir F-TAF, and so can we give her any of the short-term regimens? So what about bictegravir and rifampin interaction? And so recall that bictegravir is a 3A4 UGT1A and PGP substrate. And so this was a drug interaction pharmacokinetic study to see whether higher doses of bictegravir at 50 milligrams twice a day could offset the rifampin interaction. Now, in the package insert, it already says that you cannot use bictegravir at 50 milligrams a day with rifampin. So this was trying to see whether we can overcome that interaction. This was a PK study in healthy volunteers, 52. And I would just remind you that we do note that with healthy versus HIV infected subjects, that the data may not be comparable, so we can see higher or lower levels. But in this study, they did bictegravir F-TAF twice a day for 28 days, and then they added rifampin for another 28 days. And here in this graph, you can see that the daily BicTAF, which is in the green line, and then when rifampin was added, you see the yellow line where your levels are much, much lower. And so overall, they saw a decrease in bictegravir levels of 60% and decreased trough levels of 80%. And both of these would be below the 95 to 95% minimum inhibitory concentrations to achieve virologic suppression. So at this time, we would not give bictegravir with rifampin. And when we looked at the F-TAF, what about tenofovir alafenamide levels? They also did a PK study with rifampin, and again, 23 healthy subjects, and they did F-TAF 25 milligrams for 28 days, rifampin added on days 29 to 56. And then on days 57 to 84, they discontinued the TAF and added tenofovir disoproxil fumarate. And what you can see here is that there was a reduction in TAF area under the curve and also in the max, the area under the curve, and the C-min, the tenofovir levels here. So what was interesting here was when they looked at intracellular tenofovir diphosphate levels, which is the active moiety. Here you can see that there was a decrease in TAF levels. However, the TAF levels were still 4-fold higher with rifampin than with tenofovir, suggesting that maybe even though the actual TAF serum levels were down, the active moiety of the alafenamide was still higher with TAF and rifampin than with tenofovir disoproxil alone, suggesting that it may be efficacious still to use F-TAF with rifampin. Unfortunately, this is a PK study. We don't have data in HIV infected persons. So right now, the recommendation is not to use FTAF with rifampin and to go with tenofovir disoproxil. But I think there are some people that feel that the PK data is very suggestive that virologic efficacy can be maintained. This other graph here shows you that there was no change in M-tricytidine concentrations. So what about bictegravir and 3-HP? So the same thing was found that big concentrations were reduced an average of 40 to 57%, and the trough levels were reduced as much as 83%. Again, and this was in healthy PK data, healthy subjects with PK data. And they did do a second PK study looking at daily rifampicin or 1-HP, again in patients with HIV infection, and they did see reduction. So at least at this point, the current DHH treatment guidelines do not recommend co-administer rifampicin with bictegravir. So we're going back to our case here. So if you could please identify what your answers are for this patient who is on BIC and FTAF and what regimen you would recommend. Perfect. You guys are great. And I noticed that a number of you also picked isoniazid as the initial regimen of choice, and that is correct. So perfect. And I think if we can change her antiretroviral regimen, then we can do a number of the short-term regimens. But at this point, she would have to go with INH. Okay. So, you know, the patient says, I don't want to do 6 to 9 months of INH. I want to do a shorter 12-week regimen. So her baseline genotype shows no mutations. So she could take any antiretroviral regimen. So which of these regimens would you recommend that she can consider changing to actually use the 12-week 3-HP? Would you go with IM cabotegravir rifampicin? Would you continue her current regimen of M-tricytidine, tenofovir, alafenamide, or bictegravir? Would you go to M-tricytidine, tenofovir, disoproxil, plus dolutegravir 50 milligrams a day? Would you go to M-tricytidine, tenofovir, disoproxil, plus dolutegravir 50 milligrams twice a day, or you're not sure? Okay, we see our answers. Thank you so much for your response. And it looks like most people are picking number 4, so dolutegravir twice a day with M-tricytidine, tenofovir, disoproxil. And we'll go over that right now. So this was the Dolphin trial, which looked at dolutegravir kinetics, as well as virologic suppression with 3-HP, which is INH plus rifampicin. This was conducted in South Africa. It was a phase 1-2 trial with 61 persons with HIV, 60% women who had an undetectable viral load on efavirenz-based antiretrovirals before changing to dolutegravir, M-tricytidine, and tenofovir disoproxil. On day 58 of therapy, when they were all virologically suppressed, weekly 3-HP was given for 12 weeks. And as expected, due to the induction effects of rifamycin, there was an increase in dolutegravir clearance that was significant at 37%, and there was a reduction in overall drug concentrations, or AUC, of about 26%. But what they found was the trough concentrations remained above the 90% minimum inhibitory concentration, allowing virologic suppression to occur. And clinically, all patients maintain an undetectable viral load during the study, except for one patient who did achieve an undetectable viral load after adherence counseling. Overall, despite the combination of antiretrovirals and 3-HP, there was a very low incidence of toxicity, and it was well tolerated. So the conclusions from this Dolphin trial really changed how we treat patients on dolutegravir. And so they concluded that you could use dolutegravir 50 milligrams daily without dose adjustment. And here the caveat is that patients had to have an undetectable viral load before starting. So clinicians who want to consider giving 3-HP with 50 milligrams of dolutegravir, I think we have to have a certain amount of concern because patients had to be undetectable. So would you give this 50 milligram dolutegravir if the person was not virologically suppressed? Well, we don't have that data yet, but there is a study called the Dolphin 2, which is starting dolutegravir plus 3-HP at doses 50 milligrams a day in treatment-naive persons. And so these people would not have an undetectable viral load. And we need to look at that to see whether the effects of low-dose dolutegravir are maintained. Of course, patients would not have to have any dolutegravir resistance and would have to be definitely sensitive to once-a-day dolutegravir. So what about dolutegravir and rifampin? So this was a PK study that looked at different doses of dolutegravir, 50 milligrams once a day versus twice a day with rifampin. And here you can see the drug concentrations with dolutegravir 50 milligrams BID on the top. And then the solid line shows you dolutegravir 50 once a day. And then the second line here, the dashed lines, shows you dolutegravir 50 milligrams BID plus rifampin. So what you should see from this graph, even though this is PK, is 50 milligrams twice a day gives you an equivalent dose to 50 milligrams daily with rifampin, okay? So this is the PK. What do we see clinically? So we have data from the Inspiring trial, which is a randomized open label trial looking at persons with HIV with a CD4 counts greater than 50. And there was about over 100 patients. And these are patients who had active TB, and they were randomized 3-2 to 50 milligrams twice a day plus 2 NRTIs. And then also for 2 weeks after the TB therapy. And then the dose was reduced after the 2 weeks. And you can see that even though they were on rifampin, you can see that in the green here compared to efavirenz, that they had good virologic outcome for the most part. And the efavirenz dose did a little bit better in virologic suppression, primarily because some people had discontinued the dolutegravir, but it was really considered non-inferior in terms of the primary outcome at 52 weeks. So I think from this study, we can determine that you can use rifampin with dolutegravir if the dolutegravir is increased to 50 milligrams twice a day. Again, these patients do not have any integrase resistance, and they were virologically suppressed. So I think as clinicians, we have to worry if you have integrase resistance, this is probably not going to work because you're doing dolutegravir twice a day already. So here is a summary of what we just talked about in terms of using rifampin or rifapentin with dolutegravir, which is the integrase of choice and will require some dosing adjustments. And with other agents, I didn't talk about this, but for raltegravir, you can use the non-sustained release raltegravir dosed up to 800 twice a day with rifampin and the normal dosing with rifapentin. And because of bad PK data or lack of data at this time, we would not use it with cabotegravir or bictegravir, and of course, not with elvitegravir. And then for TAF, I've already gone over this, but to summarize, we do see decreased TAF area under the curve, but because the intracellular diphosphate active formulation of the tenofovir is higher with rifampin, then some people might suggest that you do that. And there is some data with weekly rifapentin that, again, there's no change in TAF levels, but we don't have any clinical outcome data. So at this time, the recommendations are really to use tenofovir, but if you're so inclined, you can consider TAF at either fuller doses of 25 milligrams. And there is some data that suggests that some people have done TAF 25 BID, but again, that's a hard formulation to do. So here we are back to our case. If you could please answer what antiretroviral therapy can be effectively co-administered if she was willing to change to accommodate the 3 HP data. Perfect. Okay, so most people, about half picked the 50 milligrams dolutegravir 50 milligrams data, because I guess you believe in the inspiring data, and other people picked the 50 milligrams twice a day if you're more concerned about resistance. But really, if you're going to be using 3 HP, you probably can get away with either one of these doses. But really, the better part of the data seems to indicate if you're doing rifapentin, you can do 50 milligrams once a day. Okay, let's go on to TB therapy. And I just want to emphasize that TB treatment of people with HIV is the same as for HIV negative, but because of drug interactions and overlapping drug toxicities and high pill burden and the need for more strict adherence and need for directly observed therapy, as well as the risk of IRIS or immune reconstitution syndrome, TB treatment can be more complicated. So here's our next case. This is a 55-year-old HIV positive male who has symptoms for active TB due to his non-adherence to taking INH 300 milligrams daily. And upon hospital admission, his physical exam shows lymphadenopathy and findings of a large cavitary lesion on chest X-ray. The sputum is positive for acid-fast bacteria. The expert assay shows that it is rifampin sensitive. His antiretroviral history is that he's failed several antiretroviral regimens due to non-adherence and intolerance, like many of our patients. And he hasn't taken any antiretrovirals for several months before hospital admission. His CD4 count was 40. His HIV viral load was over 100,000. Fortunately, his CBC renal and hepatic function were pretty normal. And based on his last genotype showing resistance, his last active antiretroviral regimen was ritonavir boosted darunavir at twice a day, dolutegravir twice a day, and FTDF doravirine, 1 tablet daily. And I will just tell you that based on his genotype, all his regimens were partially active, requiring twice a day dosing. So here's the current regimens for treating active TB if no antiretroviral drug-drug interactions. So we're still doing RIPE, which is isoniazid rifampin or rifabutin with PZA ethambutol at the doses here. And of course, a continuation for a total of 6 to 12 months, depending on the TB activity. And you could stop the ethambutol if he's sensitive to INH and rifampin. So his current antiretroviral therapy is restarted in the hospital, and a tuberculosis regimen of rifabutin 300, isoniazid 300, pyrazinamide 1500, and ethambutol 1200 or RIPE are started. So what adjustment is recommended in his current TB regimen to minimize a drug interaction? Would you recommend that they change his rifabutin to rifapentin, 1200 milligrams a day, reduce the rifabutin to 150 milligrams daily, change his rifabutin to rifampin, 600 milligrams daily, or reduce his rifabutin to 150 milligrams 3 times daily? Would you please answer? Okay, thank you for your answers. Looks like most people, 44% said rifabutin 150 a day. A few wanted to change to rifapentin. Some of you wanted to change the rifabutin, reduce the rifabutin to 3 times a week. Okay. So what data do we have with integrase inhibitors and rifabutin and other antiretrovirals? So fortunately, we have some PK data that shows that when you give dolutegravir 50 milligrams once a day and you add rifabutin, you can see from the curve here that there was no change in drug concentration. So we don't need any dosing changes with dolutegravir with rifabutin at 300. If you were doing cabotegravir, you can see that you can give a normal, the typical rifabutin dosing, but you do need some changes in cab dosing due to the induction effects of rifabutin. So with cabotegravir, you would do an initial dose and then do 2 weeks and then before monthly. And if the rifabutin was started after the second or later injection, you can do every other month if rifabutin is stopped. And generally, we would not do rifampin or rifapentin. And then you see the dosing with raltegravir. Now, what about rifabutin and non-nukes? So when we look at the rifabutin data, we only have PK data in healthy volunteers, so no data in people with HIV infection. And both of these PK data, we noticed that there was reduction because both doravirine and ripravirine are 3A4 substrates, that there was a reduction in levels concentration. So the recommendation in healthy subjects was to increase doravirine to 100 milligrams twice a day and to increase ripravirine to 50 milligrams daily if there were no other interacting interferences. And in these healthy subjects, the increased dose was well tolerated. And of course, no using any NRTIs except for efavirenz, which has been well documented with rifampin or daily rifapentin. So when we use rifabutin with either ritonavir or cobicistat boosted PIs, we have a number of drug interactions that are critical to consider. So rifabutin is a 3A4 substrate so that bidirectional drug interactions can occur. All PIs increase rifabutin concentrations and its active metabolite so that you can have a higher risk of rifabutin adverse effects such as uveitis or neutropenia. Previously, they had tried to reduce rifabutin to 3 times a week, but found that there was a higher risk of rifabutin resistance, and this dosing regimen has been no longer recommended. And there was minimal effects of rifabutin on PI concentrations except for cobicistat. So in our patient, what would you recommend that we do with the TB regimen? Yeah, so 77%, perfect, of you would recommend reducing the rifabutin to 150 milligrams daily, and that is the recommended answer, just to reduce the risk of rifabutin toxicity, specifically with the boosted darunavir. Some people might also try to increase the doravirine if they were concerned about virologically losing suppression, and we would maintain the dolutegravir at 50 twice a day. So in conclusion, drug interactions can complicate treatment of TB, both latent and active in people with HIV infection. I think at this point, we just need to recognize that there's a high potential for antiretroviral and TB drug interactions and loss of virologic suppression and the risk of toxicity. And really go to our drug interaction resources to assist in resolving drug interactions, because none of us can actually remember or know the outcome because they are very complicated, and we want to be able to confirm clinical outcomes with PK data. We're not often able to do that, but I would say that treatment of latent and active TB in people with HIV can be accomplished effectively and safely without compromising outcome. And so we could go back to our pre-test questions. Drug interactions between rifampin and integrase strand inhibitors occur because rifampin is a what? Okay, so 63% of you identified it has an inducer, and that is the correct answer. It doesn't really have any significant inhibitor concentration. It may be a substrate, but really the primary reason for rifampin, if you see rifampin, you should know that it is an inducer for every system that we know of. And then our next question, pretest question 2, is an increased risk of rifabutin toxicity can occur when co-administered with which of the following antiretrovirals? Bictegravir, boosted darunavir, dolutegravir, doravirine, or not sure. Perfect. Okay, so 78% of you picked darunavir, ritonavir, and that's the correct answer because rifabutin is a 3A4 substrate, and therefore darunavir, ritonavir can increase levels and increase the risk of uveitis and neutropenia. Okay. And so in the last few slides here, I'm not gonna talk about that, but it sort of summarizes all the information that we've gone over. And I've color coded it. So green means that you can use it. Yellow means that you may have some dose reductions. And of course, red are contraindicated. And so I'm going to leave you these last few slides for you to review, and it really summarizes what we've gone over. So I want to thank you for your participation, and we're into the question answer period.
Well, thanks, Betty, for a lot of very useful teaching points. And I was particularly pleased to hear you say that you can't remember all these, and therefore you have to look them up. And I have to say, for our group, we use the Liverpool drug interaction site a lot because it is updated so often. But while you listed 3, which one do you actually use the most often?
I use the Liverpool HIV drug interaction for antiretrovirals and drugs because it is updated so often. And it's updated by pharmacologists. So they put a lot of the data in there in terms of PK data, and they have good outcome data. But I think the other thing is that it's regularly updated. So they do a good job of doing that. But it's harder to do TB drugs with other drugs with the Liverpool because that's not where you go for that. And that's where I would go to Mycomedics. But thank you.
I mean, one of the issues, of course, is that when you have a trial looking at a specific drug combination, then there's data that you can rely on. Often your patient is on a number of drugs which are inhibitors and inducers, and when you have a 3-way or a 4-way interaction, I guess it's a little bit uncertain. What do you do in those situations? Make your best professional guess?
Well, if you have multiple drugs, then I would suggest that you go to the Mycomedics drug interaction because it will let you let you put in the TB drugs, other drugs, as well as the antiretrovirals. So that Mycomedics, as well as Lexicom and some of the others, will let you add as many drugs as you want. But as a pharmacologist and pharmacist, when none of those drugs are in those interacting database, then you really want to know the metabolism of each of the drugs. And then you can sort of make your best guess. Like if you know a drug is a strong substrate or a strong inducer or a strong inhibitor, you can then decide based on what your knowledge is. And that doesn't happen too much because all the FDA approved drugs have to go through some drug interaction before they are FDA approved.
Mm. And of course, the other option is just to call your clinician warm line and ask you, which is what many people do. Let's get to a couple of questions that the audience have. What about darunavir and rifampin? Are there interactions there?
Yeah, so rifampin and rifampicin are, of course, potent drug inducers, and they're not recommended to be used with any of the boosted protease inhibitors because the boosted protease levels will decrease about 75 to 80%. So really reducing efficacy and increasing your risk of virologic failure.
Okay, could you say a little bit more about adverse drug reactions with 3-HP and dolutegravir?
So I showed the slide that they had minimal drug interactions and drug adverse effects. There was one person with hypertension. There was some increase in serum creatinine, but overall it was like really very, very well tolerated, even with higher doses of dolutegravir. So we're not worried about the drug toxicity with that combination. Very well tolerated.
Yeah, a couple of people want to know about your slides, but rather than putting them up here again, they will be posted tomorrow. So if you want to see those very useful summary slides, just look at the posting tomorrow. One of the issues about rifabutin is early in the AIDS epidemic, there were a number of reports of uveitis and rifabutin toxicity, and you mentioned that. But have you actually seen that or heard of that in the last 15 years?
in the last 15 years, no, I think we always worry about the potential for rifabutin, uveitis, and neutropenia, but we are now very aware of that drug interaction. So we're taking more precautions and making sure our dose of rifabutin is low enough that that's not a problem. And in some places, they can actually do rifabutin drug levels to help titrate the dose of rifabutin for that. But I haven't seen any in the last, 15 or 20 years. And I've been around for like 40. So
Yeah, well, it's interesting that I guess when it was new,
Yes.
there were people who would report it, and I haven't seen anything for a long time. Another question is, in terms of treating latent TB, a weekly regimen certainly seems simple, but what's your personal experience with taking daily drugs versus weekly drugs? Do people really remember to take their weekly drugs? Is the compliance as good?
So that's an important point when you're using the weekly TB regimens like 3-HP. And I probably didn't talk about this too much, but most of those weekly regimens require directly observed therapy, because even though you're taking less drug and you're only taking it weekly, the adherence might be more complicated because you have to actually make a calendar to remember to take weekly medications. But most of those studies with weekly 3-HP were done with directly observed therapy. And we really do recommend directly observed therapy for any person who's HIV infected with TB for TB therapy. That is the standard of care, but it may be more difficult.
And do you do that in your UCSF clinics, or do they go to the health department for that?
We have
do they do it with an app?
They do both. I mean, we have a TB clinic here, and in some of our more indigent populations, they may have to go out and find them, but we do it with both. So there is a pretty good follow-up. And I think you do need a pretty integrated system of care to make sure that you're following up on patients with active TB. It's very, very important.
And when they do directly observed therapy, is that in person or by telemedicine?
It can be by both in person and in telemedicine if those resources are available to you to do directly via video. And in some patients that may not be helpful, but a lot of our patients, they like coming to the clinic because we also give them stipends, food, other things that make their welcome a little bit better.
All right. Well, so those are the same incentives which get residents to perform better: free food or stipends. There was a question before this that we talked a little bit about while we were waiting for this to start, is what to do about transaminase elevations. And I guess those bedevil everybody because people's transaminases go up and down. But you hear that 3 times upper limit of normal is important, 5 times is important, 10 times is normal. How do you monitor transaminases and what makes you worried or stop drugs?
Well, that's a great question, but it's a somewhat of a detailed question because we all know that INH is probably more liver toxic than most of our other agents in terms of transaminases. And even in the clinical trials, they didn't see as much liver toxicity with rifapentine than with INH. And we do know with INH that there are certain risk factors for all the agents that can increase the risk of toxicity, right? People who have underlying liver disease, people who take alcohol, people who are over the age of 40, who have other risk factors for liver toxicity. A lot of times, patients can be asymptomatic, especially early during TB therapy. And so we do expect that some of the transaminases will go up normally during TB therapy. And we have reached an area where we're feeling that 5 times the upper limit of normal is where we start to worry about drug toxicity, even asymptomatic or symptomatic. So I think it's hard to make a general question or answer for everybody, and then we really need to individualize it. And if the patient is symptomatic at even 2 times the upper limits of normal, we would try to sort of make sure that to follow that person much more quickly, like weekly, instead of longer periods of monitoring if they're asymptomatic. So I think it really depends on the patient. I don't feel like I make a general recommendation for everybody, but I still think that most people would follow weekly transaminases early on, no longer than every 2 weeks. And depending on circumstances where patients may be at greater risk for drug toxicity, we might want to follow them more closely. And of course, when you're using multiple TB drugs that all have overlapping drug toxicity, the risk increases. But and a lot of times you may not know which is the drug that's causing the toxicity, but you can, stop all the drugs, wait for the enzymes to come back to normal, and then reinduce one drug at a time within a very short period of time, has to not increase resistance, and then find out which drug is going to be the offending agent. Because once you put that drug back on, the liver enzymes will rise rapidly. So I think it's something we all need to worry about and think about. But it's TB therapy has still been very effectively completed.
Yeah, and do you think that if somebody's bilirubin rises and their transaminases are pretty stable, can you assume with reasonable certainty that this is a rifamycin, or is that not a good rule to follow?
I think that you're right, Dr. Masur, is that most of the time when we're talking about rifamycin or rifampin or rifapentin, it's mostly the bilirubin that's going to go up. And we worry about transaminases, I think, more because physiologically we expect the bilirubin to go up. But I don't think you can make that distinction. A lot of times they both go up at the same time, indicating more hepatotoxicity. And of course, if somebody's taking, hepatotoxic drugs like alcohol or analgesics or any other agents, that can also increase the risk. But I think it's hard to make, for me, it's hard to make a general statement. We want to really individualize each case.
Yeah, well, of course, we'd like a hard and fast answer, but we're not going to get one.
Yeah, I do too.
I mean, one of the nice things about isoniazid alone is that there are no drug interactions, but of course,
Yes.
Then there's toxicity, there's adherence. Do you ever use isoniazid alone for 6 to 9 months of prophylaxis anymore?
Yes, we have done it for some patients. We like not to do that because the duration of 6 or 9 months is extremely long. And we have good clinical data to show that there is a higher rate of non-completion with 6 or 9 months of isoniazid and a higher rate of drug toxicity. So we're really gravitating to the shorter 12-week therapy, which seems to work better in terms of completion rates and really fairly well tolerated. And people can just do it for 12 weeks and know that it's going to be, done, and they're going to get effective TB prophylaxis.
Somebody wanted to know about rifabutin and tenofovir or TAF. Are there interactions?
Yeah, I mean, I think that we don't have any data that says that you can't use them together. We don't have, let me just put it this way. Right now, the current recommendations are not to use rifabutin with TAF, but that you can use it with tenofovir. But that's also based on PK data. We just don't have a lot of good data. My own bias is that you probably could use either tenofovir or TAF with rifabutin, since if we look at the data for rifampin and rifapentin for rifabutin, that doesn't seem to be a major problem at this time. If you believe that the intracellular drug concentrations are what's really effective for HIV viral suppression, and that the intracellular drug concentrations are so much higher with rifampin and for rifapentin that you would expect it also for rifabutin. But I would say there's no data at this time, but I would feel comfortable using it.
All right, and the last question is, for treating TB, a 2-month regimen of ethambutol is part of the regimen. At the doses that are currently used, is optic neuritis and visual symptoms really a problem that needs to be monitored, or is that a thing of the past of higher doses, longer duration?
Are you talking, I'm sorry, are you talking about ethambutol? Oh, okay. So yeah, I mean, so the recommendations are that you consider doing baseline visual examination, but in theory, the doses of ethambutol that you see with optic neuritis were really when we were using 50 milligram per kilogram per day doses, or using higher doses in people with renal insufficiency where the ethambutol dose was not adjusted. But if you really keep to the 25 milligram per kilogram per day of ethambutol, the risk of optic neuritis is extremely low. So it's really, optic neuritis is really a drug toxicity that is dose related with ethambutol. So if you're doing the right amount of drug, you should not have to worry so much about optic neuritis, although they do recommend that you do kind of baseline to see where you're starting. This baseline optho to see where you're starting from.
Okay, well, thanks very much, Betty, for a lot of great teaching points, for some slides I think will be very useful to people, and being available to answer all these complex questions. So, Jose, what do you need to say to close this out?
Thank you, Dr. Masur and Dr. Dong, for an excellent discussion, and for Dr. Dong for your presentation. As a reminder to our audience, evaluations and information on how to claim CME and other continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's webinar. Here are a list of upcoming webinars. Next week, we have a presentation on simplifying treatment of hepatitis C and overcoming barriers secure with Dr. Arthur Kim from Harvard Medicine on July 2nd. Here is an upcoming course that we are having, the 30th annual update on HIV management in Los Angeles, California, scheduled for September 8th. And as a reminder, you may now apply to attend the Ryan White Clinical Conference scheduled from October 16th through the 19th in San Diego, California. Additional information on how to register is available on the IAS-USA website. Again, we'd like to thank our presenter and moderator, and this concludes today's webinar. Thank you, everyone.